Yes, we should start. So first of all, sir, good evening, everyone who is there in the webinar. Let me welcome you all to this webinar on COVID-19 and cardiac complications. COVID-19 has proved to be a havoc in the recent past and has proved to be a very fatal incidence to the humanity. And you doctors have had real challenge in managing COVID and post-COVID complications. Cardiac complications were one which was nagging most to the doctor and the patients. And today we are privileged to have two eminent doctors from on a panel. I would like to invite first Chairperson Dr. Anjan Lal Datta. Let me brief you about Dr. Datta. He is MD DM Cardiology and a Senior Intervention Cardiologist practicing at Kolkata. He is associated with Pearlesson Hospital, BK Birla Hospital, and BM Birla Hospital and BK Roy Hospital Research Center. And he is having an immense experience in intervention cardiology. Let me also welcome Dr. Soumitra Ray. He is MD FRCP, practicing as intervention cardiologist at AMRI Hospital, Kolkata. He is also one of the eminent cardiologists of eastern part of the country and probably the Indian continent. I request both of you to accept our warm wishes at this occasion. I also welcome all the delegates who are there from the various parts of the country in this webinar, and I am sure that the discussion which is going to happen is going to be immensely benefiting across all the geographies from where the people are present here. May I request Dr. Datta to take the chair and proceed with introduction of Dr. Soumitra Ray and invite Dr. Soumitra Ray for presentation. Over to Dr. Datta, please.
Yeah, good evening, everybody. Thanks, Alvio and his team for organizing a meet on a very contemporary issue, COVID-19. Before we start, let us pay tribute to our colleague doctors, health service workers, frontline workers who laid their lives in fight against COVID. Dr. Ray has already been introduced by you, but I must tell you that he is the Vice President, ex-Vice President of the Cardiological Society of India, and one of the prominent, most sought-after speaker in the arena of cardiovascular symposium and meeting. And I'm sure he is going to present to us a number of new facets in regard to cardiac complications of COVID-19 and measures to address those complications. With these few words, let me invite Dr. Soumitra Ray for his presentation. Dr. Ray, please.
Thank you, Professor Datta. I may also add over here that Professor Datta is not only past president of Cardiological Society of India, but he is my guide in my career in India. After I came back from UK, he introduced me to Indian practice and Indian cardiology. And I also thank the Alvio pharmaceutical company, which is perhaps known to all parts of India equally well, to arrange this particular seminar, which is not brand related. So congratulations to them. It's purely academic. Thirdly, I congratulate all the delegates who have joined today in a Saturday afternoon. I promise me and Dr. Datta won't bore you too long. We'll leave you within an hour to go back to your family. And lastly, what I want to say before starting, this COVID-19 has exposed many things in medical practice. Firstly, it has exposed that how little we know about health and disease. Number two, it has exposed that still we could not tackle a microscopical virus. Though we can make atom bombs, hydrogen bombs can go to Mars and all over the universe. But what is very much inside us, within us, we can't even tackle that. So it exposes us. And it exposes to the criticizers the gaps in allopathy system. That they are saying, look, doctor, you are saying one thing today, then another thing tomorrow. You are publishing one paper in New England Journal today and then publishing just opposite conception in Lancet tomorrow. I would say, yes, that is exposing that we are honest. We are scientists and we are not omniscient, omnipresent sort of people. We learn by our mistakes. We learn by science and experiment. So it is no quick remedy, no magic cure that we offer to people. So actually, it is good that it has exposed us, not in a bad way, but in a proper way. We are scientists, we are not magicians. Underlying health conditions in Louisiana resident with SARS-CoV infection who died last year has exposed that what are the underlying comorbid conditions which cause COVID-19 death. Hypertension was the most predominant associated condition for death, 52% patient, followed by diabetic, about 1/3 patient, heart disease, obesity, and congestive heart failure. Whereas non-cardiometabolic diseases which explained death included chronic kidney disease, chronic lung disease, cancer, neurological disease, and so on. Now, if you ask without disease, what are the other body factors, phenotypical factors, which can predispose to cardiovascular complication of COVID? The first and foremost is age. And it has been shown that of all pathological and epidemiological factors, age is the most important determinant of death. Higher the age, more the death. That was in COVID wave 1. In wave 2, the pattern has slightly changed, that all of you and we know that even the younger people are dying with equal frequency. What are the cardiovascular complications we are talking about? There are cytokine storms, inflammation, followed by acute coronary syndrome, heart failure, myocarditis, arrhythmia, and thromboembolic events. If we now see these epidemiological and comorbid conditions in India, we'll know what we are talking about. We have got 80 million diabetic in India, 200 million hypertensives in India, and 80 million cardiovascular disease people with India. So when COVID attacks India, the problem is really grim because we have got so much of vulnerable population, not only socioeconomically vulnerable, but medically vulnerable population who are liable to die. The potential target organ of COVID, we have discovered that almost all organs of the body are affected by COVID, including the lungs, the kidneys, the brain, the heart, the vascular system, as well as the gastrointestinal system. There may be other systems as well, like genitourinary system or reproductive system are also affected. How the heart is involved with COVID? There is direct cardiotoxicity mediated by angiotensin converting enzyme 2 receptor. That receptor actually attracts the virus. Second is hypoxemia, because lung is injured. We are talking about that, check the oxygen saturation. So if the oxygen saturation falls, there is damage to heart, there is damage to brain. There is supply-demand mismatch. Certain organs demand more blood during COVID, whereas the oxygen supply, blood supply decreases. And all we know that cytokine storm is a new terminology we are being acquainted with, and disseminated intravascular coagulation, which was one of the fundamental pathology which we discovered about May or June last year. And since then, with the use of blood thinners, the outcome of COVID has dramatically changed. Because previously we thought they are all ARDS and patients are dying. Now we know that they are mostly cytokine storm and thromboembolism, So with the use of heparin type medicine and steroid type medicine, we really made a somewhat victory over COVID. Now with all this pathology, what happens to the heart? There is acute coronary syndrome, there is myocarditis, there is arrhythmia, there is thromboembolism, both arterial and venous, and heart failure and cardiogenic shock. These are the 5 basic fundamental pathological changes in the cardiovascular system. Now, if we see, this is an European Society of Cardiology publication that is very nicely depicting the pathological to clinical correlation in COVID. When there is virus infection, there is direct vascular infection. So vascular cells are inflamed, endothelitis, and that causes increased heart attack. There is systemic post-inflammatory syndrome with cytokine storm and hypercoagulability. As I said, the 2 fundamental pathology which cause plaque rupture, again that can cause acute coronary syndrome. There is high sympathetic nervous system discharge, which can cause myocardial oxygen demand increase, that can cause acute coronary syndrome. And there is acute respiratory distress with hypoxia, reduced myocardial oxygen supply, which can cause acute coronary syndrome. So these are the 5 fundamental pathology which can cause a plaque rupture and acute coronary syndrome. How heart failure occurs? Something are common, like ARDS with hypoxia is common, sympathetic overstimulation with oxygen demand increase is common, myocarditis and myocyte necrosis by direct toxicity causes heart failure, post-inflammatory cytokine can cause myocardial depression, and direct myocardial infection with myocarditis, they can all cause heart failure. And how the arrhythmia increases? Again, the same 3 things. One is myocarditis, one is post-inflammatory effect, one is increased sympathetic stimulation. So these are the 3 fundamental events occurring from the 5 or 6 fundamental pathology. Chronic medical illness among all patients and patients developing cardiac injury and without cardiac injury, if you see, of all patients with cardiac injury and without cardiac injury, say hypertension. In general population, 30% are hypertensive. But those COVID patients with cardiac injury, 6% was found to be hypertensive. And those COVID patients without cardiac injury, only 23% had hypertension. Similar differences occurred with diabetes and with other chronic conditions. Now, if we see the laboratory findings at admission, which really indicate cardiac injury, and if you see the p-value, whatever we have put out here, they are all significant. One is high leukocyte count. You see, with and without, about 9,000 in contrast to about 5,000. So that is significant. Lymphocyte count is low, which is very interesting. Low lymphocyte predicts cardiac injury. A low platelet count predicts cardiac injury. High C-reactive protein, high prolactin level, high CK enzyme, M-band, high sensitivity troponin, as well as NT-proBNP. All these biochemical markers predict a cardiac injury in a COVID patient. If you see percentage of patient with one-sided pneumonia versus both-sided pneumonia, with cardiac injury, almost 90% have both-sided pneumonia, whereas without cardiac injury, only 2/3 have bilateral pneumonia. So cardiac injury indicates there is underlying bilateral pneumonia. Mortality with or without cardiac injury. If you see, in 1 month, without cardiac injury, mortality is around 5%. With cardiac injury, mortality is around 50%.
Dr. Rai, you mean with past history of cardiac injury?
No. it is during admission cardiac injury by all those markers. If there is cardiac injury occurs during the COVID infection with all those markers like NT-proBNP, like troponin I, like as I showed these markers, if they are positive, the chance of death is 50% during hospitalization within the next 1 month. The mortality during hospitalization with or without cardiac injury, okay, even those 5% people who die without cardiac injury, they die a uniform tempo of death, starting from week 1 up to week 3 or week 4. But if you see very interestingly, when the death with cardiac injury occurs, usually they occur within the first week or so, and then it becomes a bit of a plateau. That's why we tell that at 7th day, 5 to 10 days is the most difficult period of a patient's life when the cytokine storm occurs and subsequently the cardiac injury occurs and all the death events occur. If you see clinical outcome, a percentage of patients died. If we see the total, if the TNT level is high, if you see the total admitted patient in ICU, the death is 23%. If the troponin T is high, then 60% people are dying in the ICU. Whereas if the troponin is normal, then less than 10% patients are dying even in ICU. So again, this is a very interesting marker, the troponin I. Now, once you know that there is cardiac damage, how to approach early self-management, avoid cardiac event like ACS and heart failure. So take your medicines, be cautious, check your pressure, check your sugar, take rest and take healthy food, stop smoke, stop alcohol and so on. Diagnose in time, see the doctor, check the blood pressure and saturation, do an ECG and if necessary, get admitted. Therapy for severe cases, respiratory support to keep the oxygen level, circulatory support to maintain the volume and blood pressure. And drug interaction, you see certain drugs are given during COVID, which may act with already existing cardioactive drugs in the system. If we see hypertension in such patients, 1 minute. Okay. So interplay between SARS-CoV and ACE2 receptor, as I was highlighting at the beginning, COVID-19 might enter the human body by ACE2 receptor, which is present on the surface of alveolar cell. The virus may exhibit pathogenic activity by attacking type 2 alveolar epithelial cell, and ACE2 is likely to be the cellular receptor of COVID-19. And there was a concern that ACE inhibitor drug can increase the ACE2 receptor by negative feedback, and that might cause more infection of COVID, but that has been proved to be absolutely not true by all subsequent reports. As I said, hypertension is the commonest pre-morbidity, and almost in 2/3 of patients have been responsible for 60% of death caused by COVID, and it is associated with a 2.5 times higher risk of severe disease, particularly in elderly, and so it has to be controlled very quickly. I say that well-controlled hypertension is not an important risk, but it is uncontrolled hypertension and hypertension with target organ damage. These are the two groups of hypertensive patient who should be taken care of. High blood pressure you can quickly control during hospital stay, but target organ damage is really a long-term thing. You really cannot help in an acute basis. If you see the mortality, as I already highlighted, that hypertension really increases mortality by 2 to 3 times. What about diabetes? People with diabetes are more likely to experience severe symptoms like any other infection or any other injury in a diabetic life. COVID also hits the patient harder. If diabetes is well managed, then the risk is as good as general population. exactly like hypertension. So just not the history of hypertension or diabetes are important. It is the actual blood pressure and actual sugar level during the COVID infection which are important and which must be controlled aggressively. Of course, with other associated comorbidities, diabetics fare badly, like kidney damage, like heart damage, and diabetic ketoacidosis is another challenge because these patients are sometimes seriously ill with dehydration and so on. Third point is myocardial injury. Myocardial injury can result from cytokine storm, as by interleukin 6, ferritin, LDH, and D-dimer. These are the 4 markers of cytokine storm, or myocardial dysfunction from acute respiratory syndrome because of hypoxia. Cardiac troponin and NT-proBNP are increasing. Inflammatory markers like IL-6 and CRP, they also increase, and you get also D-dimer and ferritin increase. From India, there is a data from Rajasthan, cardiovascular complication and its impact on outcome. They got a single center study of 105 consecutive COVID patients, and they found that cardiovascular complication included acute cardiac injury in 26% patient, heart failure, cardiogenic shock around 3.7%, and probable myocarditis is around 2.8%. Patient with acute cardiac injury had higher mortality. My 4th point is thrombosis. A mechanism of coagulopathy and pathogenesis of thrombosis. There are risk factors. Who are the people who develop thrombosis? Acutely ill patient, immobile patient, genetically predisposed, febrile, diarrhea, dehydration, sepsis, kidney injury, liver injury, lung injury, heart injury, malignant patients. Then there are hemostatic abnormality like pulmonary microthrombi, intravascular coagulopathy, myocardial injury, increased biomarker, as already mentioned repeatedly, increased D-dimer, fibrin degradation product, etc. And ultimately, they come either by venous thromboembolism with pulmonary embolism, or even myocardial infarction, or disseminated intravascular coagulation. Thromboinflammation, you see, from normal state to COVID state, and there is in between diabetic and metabolic syndrome. So an elderly person who is obese and diabetic, they are already in a procoagulant state. So if they get COVID, their thrombocytopathy increases. So low dose of aspirin or clopidogrel or nitric oxide or prostacyclin or PDE3 inhibitor or antioxidant or even statins can help such patients. If they are already on them, they are somewhat protected from this thrombocytopathy and platelet abnormalities. If you see patient with COVID-19, DVT and pulmonary embolism, they are challenging because people are obese. Sometimes they have got venous stasis. You cannot really discern the pedal edema, sometimes very much swollen, myxomatous legs. And there are all sorts of patient is on mechanical ventilation, is hypoxic, infective. So sometimes it's very difficult to mobilize the patient to get the test done, to interpret the test as well. So if you see here that post-discharge, even after 30 days, actually it shows that they require antithrombotic to prevent this kind of thromboembolic complication, as I am showing in certain pictures, like pulmonary embolism, if you see in the arrow, short segment, venous thrombosis, if you see the hepatic veins, and so on. Now, antithrombotic therapy in patient with COVID-19, what the FDA has suggested. They have told, it is the recommendation of February 2021. Of course, there are certain changes after that, but we can always update ourselves by the Google. Laboratory testing in non-hospitalized patient, there are currently no data to support the measurement of coagulation marker. So if the patient is well enough to stay at home, you don't have to do D-dimer, PT, platelet time, platelet count, or fibrinogen. But in hospitalized patient, hematologic and coagulation parameters are routinely measured, although we do not know how to really interpret those data and how to change our management on the basis of those data. But we are developing our knowledge. Chronic anticoagulant and antiplatelet therapy, patients who are receiving anticoagulant or antiplatelet therapy for already receiving for other condition, they must continue. They should not discontinue for fear of disseminated intravascular coagulation. Patients with COVID-19 who are managed at outpatient, anticoagulant and antiplatelet therapy should not be initiated. This is a very interesting point, but again, a bit debatable. Now, what about hospitalized patient? You know, prophylactic dose of anticoagulation should be prescribed. Everybody requires heparin or enoxaparin sort of medicine, or maybe even oral anticoagulant or NOAC. Patient with COVID-19 who experience an incident thromboembolism and or are suspected to have thromboembolism, they should be given a full dose anticoagulant therapy, not the prophylactic dose. But simple example, enoxaparin 60 milligram BD instead of 40 milligram OD. As simple as that. That is the difference between therapeutic dose and prophylactic dose. There are currently insufficient data to recommend either for or against the use of thrombolytic agent when you get a acute thrombosis. 3 international trials compared the effectiveness of therapeutic dose of anticoagulation and prophylactic anticoagulation to reduce the need for organ support like ventilation, dialysis over a 3-week period in moderate to severely ill, critically CCU patient. These trials paused enrollment requiring ICU level care after an interim analysis demonstrated that futility of therapeutic anticoagulation in reducing further complication. So they showed it is futile to give anticoagulant in moderate to severely ill patient to prevent further organ damage. After hospital discharge, VTE prophylaxis is not recommended. Though some of us are still giving 1 month or 40 days of rivaroxaban or some that kind of medicine just to prevent, but it is very, very debatable. It depends on individual clinical judgment. For certain high VTE risk patient without COVID, post-discharge prophylaxis has been shown to be beneficial. So FDA has given 10 milligram rivaroxaban for 30 days to 40 days in these patients. So here, COVID is not a criteria. It's a sick patient, immobile patient, otherwise patients who are prone to thromboembolism. COVID has got nothing to do. And these include improved VTE risk score of 4 or more, modified improved risk score 2 or more, or D-dimer level 2 or more. So these are the certain criteria. So certainly we can go by the D-dimer, and if the D-dimer is more than double in an obese patient who is immobile otherwise, there is a case for giving rivaroxaban 10 milligram daily for a month or 40 days. Now, bleeding and clotting events following COVID vaccination, I think it is a ever-changing field. I leave it for my chairman's comment after my speech. Coming to the next area of heart, that is arrhythmia. Arrhythmia in patient with COVID-19 that can occur from myocardial injury, that could be atrial fibrillation, ventricular arrhythmia, or heart block. It could be antibiotic or antiviral medicine induced like long QT syndrome, sudden cardiac death, or heart block. There may be other drug-drug interaction, or there may be lung injury, inflammation, and sympathetic stimulation, we can call atrial fibrillation as well as ventricular fibrillation. The same center from Indian, Rajasthan, 105 consecutive COVID patients showed sinus tachycardia in about 17% cases, first degree heart block in 5%, VT-VF in 2%, sinus bradycardia is very rare, QTC prolongation was rather very high, almost 20%. An acute cardiac injury, lymphopenia, use of inotropic agent, and neutrophilic monocyte were independently associated with arrhythmia. So very interestingly, a low lymphocyte count, which we usually don't care about, is a bad prognostic marker. Acute treatment of new atrial fibrillation, ESC has given the guideline if the patient is hemodynamically stable, but the ventricular rate is fast and there is acute pulmonary embolism, then you have to do a rate control with beta blocker, diltiazem or verapamil, amiodarone or diltiazem or digitalis, plus anticoagulation as per normal protocol. Reassess the rhythm after recovery from COVID-19 infection and reevaluate whether you want to convert the patient to sinus rhythm, but no acute conversion. If the patient is hemodynamically unstable, then you have to convert, there is no option. Plus you give the rhythm control mechanism like propafenone or amiodarone with anticoagulation. And to draw your attention, we commonly give azithromycin or hydroxychloroquine. They interact with NOACs, like hydroxychloroquine is all right with apixaban and rivaroxaban, but there is some warning with dabigatran. Azithromycin is all right with maybe some warning with dabigatran and rivaroxaban. Apixaban, there is no data. Like warfarin, it's contraindicated with azithromycin. With chloroquine, it is okay. Like heparin and azithromycin is a bit contraindicated, but with chloroquine, hydroxychloroquine, they are okay. So this chart actually gives you on the left side the drugs you are using for COVID, and on the top the commonly used drugs the patient may take because of anticoagulation and how they interact. QTC management is also given by ESC, that consider no ECG before starting therapy if the patient has got a recent ECG with a normal QTC, no history of structural heart disease, arrhythmia or syncope, no history of acquired or congenital long QT, and no bradycardia. Then you do not do ECG. Otherwise, you have to do an ECG. And also correct all the modifiable QT prolonging factor, like concomitant drugs. Very commonly, our teneligliptin, we have to stop it. Like azithromycin, we have to stop it. Keep serum potassium well above 3.5. Routine magnesium may be given. Avoid bradycardia. If you cannot ensure this, you have to do the ECG. If the ECG shows QTC less than 500, you start the COVID-19 treatment and do the ECG after 1 day. If the initial ECG shows QTC is more than 500, then you have to evaluate the risk versus benefit of COVID medicines. If started, put patient on telemetry. So you see, COVID treatment has got a very interesting interplay with QTC, with ECG, and the role of cardiologist. Next, the acute coronary syndrome. Troponin elevation in the setting of COVID can be related to non-ischemic myocardial injury. So troponin elevation in COVID does not mean it is a heart attack. It can be myocarditis as well. As we already mentioned, the mechanisms of acute coronary syndrome. What to do if a patient with ACS, suspected ACS, comes to emergency? You will do the emergency access checklist to assess the probability of COVID infection. If you think there is no COVID, normal management. If there is a possibility of COVID, you take to an intermediate ward and do the rapid antigen test nowadays. If negative, then send him to normal ward. If positive, send him to COVID ward, and the management varies slightly. Patient with STEMI during COVID-19 pandemic, access to care, STEMI network. If the patient is going into a hospital with cath lab, with primary PCI, which has got a dedicated COVID cath lab, then you go for primary PCI. Otherwise, you go for a fibrinolysis. So fibrinolysis is very much encouraged in COVID setup. Even in non-ST-ACS, non-STEMI, not STEMI, but non-ST-ACS, we only in very high risk patient, we take straight to cath lab. But in high risk and intermediate risk, we first take the patient for COVID testing. If negative, then we do the usual management. If positive, then we are really reluctant to take the patient to cath lab and try to manage him conservatively. And low risk patient, we always manage conservatively. We from in Cardiological Society of India, I'm part of it, actually published our paper last month, MI admission multi-center study of 27 states across India, and we concluded COVID-19 pandemic situation has changed the paradigm for management. We get unexpected finding, many typical acute coronary syndrome in cath lab. The coronaries are normal, or there are embolism or thrombus. After thrombosuction, there is no lesion. So these things we are getting, and primary PCI versus lytic therapy is very closely looked into. And not only lytic therapy, the usual thing is that pharmacoinvasive therapy, that you thrombolize and within 24 hours, you take the patient to cath lab. But here also we are doing a bar that look, if the patient is stable, inferior wall MI, thrombolysis is successful, and the patient is COVID positive, you don't have to do the angiogram within 24 hours. Discharge the patient after 3 to 5 days. Once the patient is negative, after 2 to 3 weeks, you bring back the patient and do the angiogram. So it is not pharmacoinvasive, it is delayed invasive after thrombolysis. So a new terminology has been coined, delayed invasive technique. So COVID-19 fears put interventional cardiology on lockdown, so that we know it is not from India, it is from Spain. 40% in Spain has dropped. It is actually all over the world. The cath labs were redundant, they were empty. And the mystery of missing STEMI during COVID-19, some people died silently, but our Burning Heart and funeral centers did not say that. They did not say that many more bodies are being burned. So it's not that they are dying of heart attack silently. Number two, so they are surviving somehow. So what we are expecting to get are more heart failure patient. So incompletely revascularized patient, the chronic total occlusion patient, and ischemic cardiomyopathy patient. These are increasing and these will increase. And lastly, the heart failure. We again published our paper of CSI. We are part of it, that COVID-19 and heart failure. And we recognize that COVID-19 global pandemic has endowed humanity with a huge impact. Many patients develop myocardial injury, which can lead to significant cardiovascular complication, including heart failure. Guideline-directed drug therapy, which include RAS blockade, aldosterone blockade, beta blockade, and nowadays SGLT2 inhibitor. You know that their trial with SGLT2 inhibitor is a neutral and partially successful trial. They are to be continued in patients with pre-existing heart failure. Long-term cardiovascular effects are yet to be ascertained. Cardiac drug options, ACE inhibitor, ARB, very important. You must continue if you are taking that. Antiplatelet drug, continue take the medicines and do not stop them even for vaccination, not for a single dose. Even for warfarin, even for NOAC, do not stop the medicine on the day of vaccination or the day before or day after. Please do not do that. NSAID, data equivocal. Nowadays it's saying that NSAID are good to treat the myocarditis. Even the vaccine-induced myocarditis, NSAID and steroid are very helpful. Statins are interesting drugs. They are plaque stabilized, anti-inflammatory, but you have to see the effect of statin in the liver because liver is at jeopardy, and beta blockers should be continued unless there is active bronchospasm. Last slide, we come in from the Katrina. Katrina, you know, occurred about 10 years ago in the eastern coast of America, and lesson learned from Katrina. 10 years post-Katrina, coronary artery disease increased by 47%, diabetes by 40%, hypertension by 80%, dyslipidemia by 60%, smoking increased by double, medical non-adherence doubled, psychiatric illness more than doubled, drug abuse increased. So it is a long-term social, economical, psychological effect. It's just not medical effect. These effects can affect our medical community. So COVID, even if we conquer COVID next year, we have to be ready for the next 10 years for all the post-COVID complications, which will include depression and drug abuse and alcohol and smoking. But for the time being, we have to protect ourselves first to see and to tackle all these. So use all possible precautions and stay safe. Thank you very much.
Thank you, Dr. Roy, for your excellent deliberation. It was really thought-provoking, newer insights into the scenario of COVID-19 in terms of cardiac involvement. We'll have, I believe, a lot of questions or queries from the chat box. The host is requested to raise the questions so that we can read it out and Dr. Roy may be asked to answer those questions. Before the questions come up, I have a few questions or points to make. Firstly, the hydroxyquinoline, or for that matter, the azithromycin, which were once considered as a drug of choice, the initial stage of treatment of COVID, ICMR is negated now. We are not using the drug as a routine treatment. So do you think that there was an impact of prolonged QT interval by these two drugs? Because in the algorithm, you said if the patient is receiving treatment, you take care that it is not increasing the QT intervals. Is there any other drugs likely to increase QT interval other than these two drugs?
Yes, as I mentioned, a commonly used drug like teneligliptin, like erythromycin, like amiodarone, these can increase QT.
I mean, about this particularly for COVID, azithromycin and
No, but even in the chart you have seen that there is maybe the antiviral drugs, some of the retroviral drugs can increase QTc. So that's why, that's why it is said that once you are treating with specific antiviral drugs, you must do an ECG very frequently to see that whether QTc is being prolonged. And if it is being prolonged, either you change the medicine or you keep the patient on constant cardiac ECG monitoring.
That is true. I want to tell you that these two drugs have been banned or have been negated for treatment of COVID. Isn't it correct?
No, I mean, it's again very controversial, Professor Datto, that of course, as initial hype in the America and in India has died down, that they are not so much helpful, but many people are still taking, and particularly in
the ICMR has categorically said no.
Yes, but in early symptom, you will see 90% of our physicians are still giving a course of azithromycin.
That should be the message gone. That it should not be used because ICMR has categorically said no.
Yes, there's no effect.
The second question is more academic. The involvement of AC2 by the COVID virus as a carrier to the lung, because it is found mostly in the alveolar type 2. Apart from that, the AC2, ACI2, converts angiotensin 2 to NG1 and 7. This NG1 and 7 is vasodilator anti-inflammatory. It works through the MAS receptors. Or in other words, angiotensin 1,7 or NG17 is anti-inflammatory, vasodilatory, and good for myocardial physiology. So if AC2 is being affected by the virus, there is additional harmful effect because the NG17 benefit is lost?
Yeah, there are always theories about the 1 to 14 of angiotensin, and then there are receptors. AT receptor also, there are 9 or 10 AT receptors. And when the angiotensin works, they not only work on 81, they work on 82, 87, 89, and 12 also. So they all have contradicting effect. And so it is always controversial. Again, it is a usual debate whether ACE inhibitor versus ARB, what is better because of different modes of action, different receptor action. So it is very complicated area, and honestly speaking, nobody knows what is the resultant outcome in a particular patient. Which receptor is more in number, which angiotensin is more in quantity in his body, nobody knows. So that's why there is differing action of ACE inhibitor and ARB on different human being in health and in disease. So these are all theoretical discussions. The ultimate recommendation is that don't get scared about ACE inhibitor or ARB with or without COVID. If it is indicated for whatever reason, just go on giving it. Don't bother about COVID.
Yeah, that is one of the reasons as to why don't stop it. Because ACE2, if ACE2 stopping means Ang-17 stopping. And that means the beneficial effect is lost. In any case, any other questions from the chat box?
Yes, sir, there is one question. There are a couple of questions are there.
Yeah, please place it for us.
I can see. Please highlight. I can see one, sir. Please highlight it. Dr. M.K. Chowdhury. Please highlight some point about role of dabigatran after discharge of COVID patient, which was earlier on enoxaparin. Can we advise it or not? As I said that
the question in the screen. Yeah.
Most recent FDA guideline is that you do not have to give dabigatran or rivaroxaban or anything post discharge just for COVID. But if the patient has got other high risk factors for thromboembolism, which includes a high D dimer, and if the patient was getting enoxaparin, then you might continue the oral anticoagulant for 31 to 39 days, depending on patient profile post discharge. But that is with or without COVID. Even a non-COVID patient, say a post-operative patient who is immobile after hip replacement, he is very obese and there is a phenastasis, though there is not even a DVT, you can give a month or so off. So that is by the VTE score as well as by D dimer. But naturally, COVID might shift you to give it more liberally. Many people are giving for a month or so, particularly if the patient is not too old, because we know that thromboembolism is occurring more in a younger patient. So younger patients can be given safely for a month course of dabigatran or rivaroxaban, but in a low dose. If dabigatran, it is 110 BD, even 75 BD. For rivaroxaban, it is 10 milligram OD. For apixaban, it is 2.5 BD. So it is a lower dose, not the therapeutic dose.
The question is is pregnant women can be vaccinated against COVID-19?
Only today, India government has circulated that they have done the trials and it's coming up that it will be safe. It is already permitted in many European countries and America. So pregnancy is safe, but we have to wait for our India government policy.
Exactly. It is only come up today. I have a question. Those patients who are, as per guidelines, who are admitted should have a prophylaxis against venous thrombosis in the form of Clexane or heparin. Now, in their country, those who are requiring admission is admitted. But in our country, many of our patients who are fit to be admitted are not admitted. So those who are not even admitted, those patients, some of them may require thromboprophylaxis in terms of injection anticoagulant. How do you assess it?
It's a very intelligent question. So you have to not go by the actual admission status, but you have to go by the patient's criteria for admission. Exactly. If the patient fulfill the criteria of admission, like the saturation, the pulse, the blood pressure, the fever, patient's well-being, patient is fit, but either he is not getting a bed or he is reluctant to be admitted or he has got enough home support. So for various reasons, he is not admitted. But he is a candidate who is otherwise would have been admitted.
So that is an issue for our country.
So this patient requires a prophylactic dose like Clexane, 40 milligrams subcutaneous OD.
Even if they are at home.
Yes.
Secondly, the Canadian Society of Cardiology recommendations, they say you are giving prophylactic dose of enoxaparin, say 40 ml. But if you find the D-dimer remaining high, despite that, if the patient does not have any clinical evidence of thromboembolism or VT, you can upgrade that dose. They say you can increase the prophylactic dose from 40 to 80 milligram OD or 60 milligram OD. So they have given 3 doses. One is a prophylactic dose, one is upgrade prophylactic dose, and third is a therapeutic dose. So there is one
Exactly.
between the two.
I have shown already that in a proven case of DVT or a suspected case of DVT, in certain situation you may not prove it because the patient is too moribund, you cannot shift him to do a test, or the patient has got multiple comorbidities when you cannot really interpret the lung finding or the venous finding or the ultrasound finding. But if you suspect that there is a DVT by circumstantial evidence, then you have to give the full therapeutic dose, no longer a prophylactic dose. It's already FDA recommended as well.
Okay, they said apart from that, the third group is that
it's high prophylactic. Yes, high prophylactic. Okay, it's in between. It's in between.
Yeah, D-dimer not coming down.
It's in between. Yes.
There is a question as to whether D-dimer should be considered as a pro-inflammatory or as a marker of thrombosis.
Traditionally, it is a thromboembolic marker. We do it for DVT or pulmonary embolism. But this COVID has shown us many things. Now, D-dimer is equally being said as an inflammatory marker, like TROP-I is now a myocarditis marker. ProBNP is an ACS marker. So the markers are losing their boundaries. They are not compartmentalized that this is for heart failure, this is for ACS, this is for DVT. So I think a battery of marker should be there, like we are saying that NT-proBNP, troponin, D-dimer, interleukin-6, with or without LDH, with or without lymphocyte count. So these are the 4 or 6 battery of tests which should be done on alternate day during hospitalization, maybe on the 7th day after discharge, and which I personally recommend on the 14th, 15th day before the patient joins office. Because many patients we are seeing, just one second, many patients we are seeing who are having sudden cardiac death on the day they are going to office or going to active life after 14 or 20 days of complete normal home stay. So this is a very interesting period, 2nd or 3rd week. I think you should have a hospital checkup or doctor's checkup, including these few biomarkers. And I recommend an ECG and echocardiogram as well, because we're seeing many silent myocarditis patients, which are there, they don't know, they just go to office and die in the public transport with acute chest pain.
Yeah, exactly.
So Dr. Yeah.
That was the question. Would you please show the previous question? Keep the question on. Doctor's name should be there. The last question. The patient dying after being discharged.
Yeah, Dr. Seema Sultana, she has said some patient die after some times of recovery of COVID.
Yeah.
Is there any known reason?
Yeah, that is exactly the question answered given by Dr. Swarmitra Rai.
Right, sir.
So I think Dr. Dotto, I am not seeing anybody bringing a protocol, but there should be an urgent need of a protocol of how a patient, when he should join his normal life,
Exactly.
even after a mild attack of COVID. You not necessarily have to be hospitalized. Even after a mild attack of COVID, I see many of my colleagues also, the doctors, are going back to full work in 7th day, 10th day, and many of them are having a relapse and are dying in the 2nd or 3rd week.
Exactly. And the term has come as a prolonged COVID.
Yes.
The term has come as the issue is that one thing we agree that before the second wave, in the first wave, we had a very good number, an increased number of mortality compared to the number of person affected. We learned something from the first wave. And one of the things that we learned mostly is the use of steroid to combat the cytokine storm, which occurs about 10-12 days. And this use of steroid to combat cytokine storm resulted not only in depressing or getting rid of cytokine storm, the effect of cytokine storm, like myocarditis, like heart failure, like morbidity and mortality from different causes. So do you think the patients who are suspected to have thromboprophylaxis suspected to have thromboembolism, suspected to have inflammatory markers raised, because thromboembolism markers are also inflammatory markers. Do you think that we should be more careful or more liberal in using steroid at least 7 or 10 days onwards when you see the markers inflamed? Although there is a chance of mucormycosis, but even then, I just want to know your opinion about use of steroid.
Yes, actually, this is again a very controversial issue, and very difficult from my position to give some opinion, because that might be contradicting to Ministry of Health and Family Welfare regulations. But many of the, I think when heparin you are giving in a moderately to serious patient, a short course of steroid should at least be given 7 to 10 days with a rapid tapering. You have to be careful about mucormycosis, particularly in diabetic subset. And while giving steroid, be careful about increasing blood pressure and blood sugar and chance of secondary infection. Also, some people tried colchicine as an anti-inflammatory marker, but very recently, again, there was negative result of colchicine that it really did not change anything. But still, in many big corporate hospitals also, some doctors are giving routine colchicine. So these are varying practice.
Because most of our colleagues of the critical care department who are treating COVID, they say compared to the first wave, the second wave patients are being treated more effectively because of a more liberal use of steroids. So they say that we did not use steroids so liberally in the first wave, and that is why we lost a good number of patients who could have otherwise been saved. So that is, we are at the crossroad in that is something we should know about it.
Absolutely. I mentioned in my talk also that heparin and steroid, whenever we started these two medicines in the routine management of COVID, particularly from last year, May, June, the death rate drastically fell. We previously thought it was ARDS and people will require the ventilation, but then it was shown that it is not a ventilatory problem. It is a steroid and heparin dependent. So one side there is inflammation, one side there is microembolism. So these two are the basic pathology. It's not lung damage or not ARDS.
Any other question from the chat box?
I see here, if a patient is on teneligliptin, is from Dr. Kanad Kumar Dash, diagnosed COVID, is it necessary to stop teneligliptin as a precautionary measure? Look, it's yes and no. Teneligliptin in any condition where QTC may be prolonged is condemned. So teneligliptin is not a drug of choice, but at the same time, if you stop teneligliptin, your sugar may increase, which is bad for a COVID patient. So I would rather say replace the teneligliptin with some other gliptin which does not have the QTC prolonging thing. In fact, any other gliptin, no other gliptin has got QTC prolonging property except in teneligliptin. For at least for the time being, you sacrifice the teneligliptin, give something else, and we got cheaper gliptins as well nowadays in India.
In any case, teneligliptin is not a very important, essential drug. We have a lot of antidiabetics.
Yeah, but you have to take care of the sugar. Yeah.
Yeah. There was another question here. Some new. Yeah.
Endothelitis is a primary event leading to organ damage. Should all patients be started with antiplatelet from beginning? Now, this is an interesting question. Many clinicians are giving an aspirin or clopidogrel with a statin in all patients with COVID. It's difficult to justify on a evidence-based medicine, but it makes sense. It makes sense. At least for 6 to 8 weeks, you can give a mild antiplatelet. If the patient you are not giving anticoagulant, then a mild antiplatelet with a standard dose of statin like atorvastatin 10 milligram, you may give, but be careful about the liver damage and other things.
Yeah, the problem is that there are reports of hemorrhages also.
Yes. Dr. Datta, a question for you. Will there be any issue if second dose of COVID vaccine, say Covishield, is taken within 30 to 45 days, since as per the current report, it is recommended to take after 82 days?
Some few lakhs of patients, including doctors and frontline workers, have already taken COVID second dose within 4 weeks. Not within 4 weeks, within 30 days, just after 4 weeks. And they are, as of now, doing fine.
So many of my colleagues have got in 30 days, We are in the second batch, so we got in 42 days. Now my colleagues are in the third batch, they are getting in 82 days, and maybe there will be fourth batch who will take it, I don't know when.
But
So,
what if there may be down squad, they'll come
so
back again.
whether it is scientific or whether it is need-based, demand-based recommendation, we really don't know, and we don't really want to comment because these are very tricky areas. We are really nobody to comment on this. So go by the government policy.
It was initially suggested from the Oxford that delaying by 2 weeks leads to better immunity response. So that is why there was a suggestion came from there only first, and then the government of India jumped to accept it.
Yes.
Coming back to your questions, whether COVID vaccine has anything to do with myocarditis or not.
Yes, that's a big issue.
The issue is highlighted very recently, even 2 days back, there is a news that the FDA has suggested a black box type of warning that all patients receiving vaccines, particularly the RNA, mRNA vaccines, Pfizer's and Corona, are likely to get myocarditis. They have till now studied some 1,000 patients out of some few millions, which amounts to about less than 1%, even less than 0.1%. And they find that the most of the patients who got myocarditis are in the age group of 30 and below, and all of them are cured. There is not a single fatality reported, and most of the symptoms related to myocarditis are like chest pain, breathing difficulties, and weakness, occasional fevers. And these patients, they get the symptoms mostly after the second dose, but all of them have got cured within few days. None of them had died, and most of them are young patients. So these evidence of myocarditis after taking second dose of mRNA vaccine like Corona, Modern and Pfizer's vaccines are for them only. There is no evidence as yet of adenovirus like Covishield or Covaxin related myocarditis. So we don't have to worry about myocarditis so far as vaccination is concerned in India, or for that matter, even globally also, there is no extra concern because the incidence is so low, mortality is nil. So the danger of not taking is far more than the minimum danger of getting a little bit of myocarditis or pericarditis.
Exactly. And also, if you get also myocarditis, the treatment is again a short course of steroid with tapering dose, anti-inflammatory like NSAID, colchicine with aspirin, and also beta blocker, which is very important because that can prevent the sudden arrhythmic death in case of myocarditis, heart failure, acute coronary syndrome. All the three important issues which occur in COVID heart can be taken care of by giving beta blocker. So beta blocker use should increase unless there is active bronchospasm. So if there is no other question, we have kept our promise to.
But I would reiterate your one particular warning for all of us, for all the listeners. Please make sure that one who had a COVID-19 infection, be it mild, moderate, or severe, he or she should not join office without the permission of the treating doctors at least 4 to 6 weeks after the first incidence of infection. Make sure, please don't join your work without the advice of your treating physicians, and at least take rest for 4 to 6 weeks. And if possible, do a second echo and ECG, and if necessary, other investigations related to your symptoms.
The problem is that the insurance company or the employers do not give a month's holiday after COVID. They give the 10 days, something like that. So this is an important issue which is not in our hand. This is a various stakeholders. People should be aware that at least up 2 weeks, and after 2 weeks there should be a thorough medical checkup, and they should join with a medical fitness certificate. I think at least that should be a minimum requirement to prevent these untimely, unnecessary deaths.
And there is a latest new marker, inflammatory marker, is ferritin. That is
ferritin. Yes.
That is likely to remain high as well.
Yes. So, Dr. Datta, you can close and give the mic back to Mr. Manish.
So all good things should come to an end. Thank you very much, Dr. Soumitra Rai. Thanks to all the participants for their vibrant questions and active participations. Now, back to Al-Nitra team for their.
Yeah, thank you, Dr. Thank you, Dr. Ray, and thank you, Dr. Datta. You have been very, very informative to us. I am sure that people across the country who have been a participant to this webinar must have been benefited by the experience and the sharing of the knowledge which you have acquired during COVID-19 treatment protocols. I'm very, very thankful on behalf of Albio, and I would like to continue this journey furthermore. And thanks for your time, for everyone for your time to be in webinar on COVID-19 and cardiac complications. Thank you very much.
Thank you very much.
Thank you.
Thank you very much, sir. Thank you, doctor. Thank you.